Okay, so, now the Zoom also records. So hi, I'm Eduard Brüll. Today I'm presenting two projects. Actually, it's a bit of starting research agenda into health. And the one is a very early in progress project, and the other one, the secondary part, is recently published in Labor Economics. But both rely on the same data infrastructure and on the same institutional detail in Germany, and both are projects on primary care. And if you have any questions at any time during my presentation, just ask. And now the clicker works. Okay, so as I said, it's a project on primary care and mostly on general practitioners. And general practitioners are typically the first point of contact in most health systems. It's the family doctor or primary care practitioner. And these are the people that do most of the consultation work and the first point of contact for people who have to do with the healthcare system. And a lot of preventive measures and chronic disease management and gatekeeping to specialists and hospitals is done through primary care, to outpatient care. And GP access is regulated actually in most countries. So Hungary has the single payer system with vacancies and so on. But in Germany, you have something that looks more like a free market, but you have entry restrictions to balance regional needs and over provisions. So why entry restrictions? The idea that behind regulation is that not all physicians enter in the most attractive markets. So perhaps all of them are educated in Heidelberg or Berlin or nice larger cities where you could also get more from patients or have more privately insured patients. But you want to distribute GPs that they not only go to Berlin, so you close Berlin if you're overcovered, if you say that you have enough GPs per 10,000 people. So then if you want to set up a GP practice, you have to go to another place. And here we look at an entry restriction, but on more than just access control. We want to look at the rule itself, at changes in that rule, but also on GP competition and effects of competition. And these are two projects here. And first, I'll explain how the planning system actually works. So what it's called is needs-based planning. So the idea is to prevent undersupply by subsidizing settlement or oversupply by blocking entry. And we look at the second part, at the blocking of entry. And one thing about regulation is an institutional peculiarity of Germany. So Germany has a really complicated landscape of the healthcare system. So you have statutory insurance. These are insurances that are basically public. So this is the one that you have to take up if you are a normal employee. And you have private insurances that are only for self-employed and civil servants. And 90% of the patients are in the statutory insurance. And in the statutory insurance, prices and rates are completely controlled. So both on the patient side and on the doctor side. So there's more or less complete price controls. It's you have multiple insurances. I can go to AOK or Techniker Krankenkasse or others, but they are basically identical. There are sometimes copay differences or differences in extra things they pay for preventive care, but it generally doesn't matter. And 90% of the population is there, and roughly 85% of the revenue of GPs comes from the statutory insurance. So on average. And this planning on the regional level is also not done by the state itself, but by regional associations of the statutory health insurance and the associations of the physicians. So the physicians have an association, and they plan together with the health insurance what the target for a region should be. And if the target is exceeded by 10%, you have automatic blocking. So no new practice is allowed to enter into the market. And here I will combine insights from two related studies. There's an actual access, that's a new study, and it's called Keeping the Doctor Away. It's about the blocking in regions, and it's an early stage diff paper that looks at the 2013 reform of the entry restrictions, where these entry restrictions were harmonized across regions. So, and with this harmonization between regions, that the planning was now used the same restriction, a lot of regions were immediately blocked to entry. So no new GPs could set up. And we want to look how population health is affected and what happens to the market structure when entry is blocked. And the big question behind this is, what's the value of an additional doctor? Did we actually have oversupply, or did we close-off regions that could have used that doctor. And the second one is a study on the threat of entry. It's called Cutoff from New Competition, recently published in Labor Economics. And it's the RDD at the cutoff. So you look what happens to local monopolist GPs if they now don't have to fear that a new competitor will enter. You compare them just around the cutoff. And we just look what they do if no nearby competitors can pop up.
And the second one, what's the outcome? So what do you see that you look at GPs, what their pricing or their health?
So pricing we don't really observe. So prices are regulated anyway. So in the end, it's measures of effort and quality. And we have doctor ratings there, and we have population health on the regional level. But in the end, we don't really have individual health directly linked, but it's mostly doctor ratings. Web scraped from the largest rating website in Germany. Quick preview on the results. So in the keeping the doctor away, we see a lower number of GPs in affected regions. That is what we already can cleanly show, and can show you that we have clean identification there. We see that practice composition is not that much affected over the term we look into it. So the kind of practices you have are still relatively similar. And you see that there are some shifts in the competitive environment. But here's the reason why I'm doing the combined talk. So we still have a lot of ongoing work, and we don't have the health outcomes yet. So Germany is just opening up new health data. I will talk about this in a minute, but we don't really have the health outcomes yet, and we don't really have the spillovers to specialist care yet. And this will take probably a few months till we have them, but till then I can show you that we can cleanly identify reform variation, but cannot do much interesting things with it. And the second one is the finished paper. There I can show you some results. So we see no change in GP density or coverage at the threshold. What we should see, so there's nothing in actual competition that changes, just the threat of entry. But then we see lower quality in local monopolists. So the people that have no other GP nearby in a kilometer of range in walking distance show that they have lower patient satisfaction, but we see no strong regional health effects. So in the end, it's probably just that they're a little bit less friendly or putting less effort into patient communication. That is how we interpret it, or we don't measure the health effects well. That could be the other way to look into it. And the interesting thing is that here we see an example of the threat of entry that disciplines competition itself. So where you don't need, so actual competition is probably still better, but care quality is affected by the threat of entry. So let's jump into the keeping the doctor away. Before 2013 in Germany, GP availability varied widely between planning regions, from 4 GPs per 10,000 people, 4.5 GPs per 10,000 people to 9 GPs per 10,000 people. And the targets that associations set were very different for different regions. And what the reform mainly did is that it established a national standard for the target. So it was 6.65 GPs per 10,000 people. So if you ask yourself where this number is coming from, it's the average for West Germany in 1992. So it's not the smartest way to think of this reform. So it's almost, yeah.
For children and for adults, or is it only for?
It's overall for all people. So it was. There's later an adjustment allowed on demographics in there. It's also a little bit in the reform, but it only shifts this target very little. So, and much later there's a morbidity adjustment, but this happens in 2019 after the end of our sample frame. This is another reform where morbidity goes into it, population morbidity, but it's also no big adjustment.
And so then the same GP serves was the children and the adults, because it's split. So
generally you have GPs both for children and adults for a lot of things you treat, but you have separate doctors just for children. So for early, how are they called? Pediatricians. So you also have pediatricians. They are regulated by a similar system. We don't look at them. So one of the reasons why we look at this very broad things like the main GPs first is because they are planned on very small regional levels, and some of the specialists are planned on very large regional levels. So, for example, radiologists are planned at the state level, which leads to weird distributions of radiologists across states. So Baden-Württemberg as a whole state in South Germany has them planned at the state level, and a third of them are in Stuttgart. So, which is something that then can happen. What this reform also did is that it introduced a more fine-grained planning of the more fine-grained planning region that is more granular. This is a unit below the counties. So usually Germany is structured in counties, and Mittelbereiche are regions from municipalities, so really small regions. It's the local center of life for people, and these regions also shift a lot. But what we do here for this first project is to just track the entry restrictions at the Kreis level, which we can do because it's a pure subset. And the interesting thing here is that roughly 27% of regions are now immediately blocked. Then we have an immediate closing of entry in 27% of the regions. And for the data, we have to combine a lot of different things at the moment, because we don't really have a need collection that is directly available. So what we needed was annual need-based planning reports from these associations of SHI accredited medical doctors at the planning area level. And these contain our locally adjusted targets and the coverage rates. So this is administrative data from that group. Then we had to use the regional database of the Federal Statistical Office to get all our controls, population, local income tax, age structure, share of people in need of long-term nursing care, and the INCA database from the Federal Office, also from the Federal, not from the Federal Statistical Office. It's another group in Germany that had other county level data also on health. And we coded some novel microgeographic things. So we got an excerpt of all the yellow pages in Germany from a friendly hacker from Germany's Hacker Association, the Chaos Computer Club, who gave us all the info that was in the yellow page CDs for Germany over many years. He collected that for some reason. And it was already geocoded, and it's a geocoded panel of GPs for every year in our sample period. So we have them with exact geo-coordinates. And then we have the 100-meter grid of the German census. So there's Germany in the census has 27 million 100-meter cells, where you get the exact population number within those cells. And we could then compute access and competition measures for our regions based on this microgeographic data. So we have the distance to each GP from each cell, and also the amount of patients in different buffers and so on computed from that.
We have occupation in this yellow pages data.
This yellow pages data, we have basically the practices, the firms. So it's a GP practice. You don't really see who they hire, but you see the people themselves, and you know that they are allowed to practice as a GP. What we plan to do next is Germany's new great data on health. So FDZ Gesundheit is a project by the Federal Ministry of Health that will just open up. And this will combine the insurance claims from all statutory insurances, also some data from private insurances, medication, diagnosis, and medication and diagnosis are probably relatively important for us. So it's a little bit more than just claims data, and that we can then link later to our regional data. Alternatively, we will just go for one health insurance. We're already in talks with one, and we want to finish this project in the foreseeable future. And at the moment, it looks like so officially FDZ Gesundheit should start at the start of the year. Then we did an application for that, and they said, okay, you get it in May, or end of April, but now it's May. So we'll see later. But we also have this microgeographic data from hospital reports. So for every hospital, we have the exact geo-coordinate plus a range of hospital beds, what kind of treatments they have, then plus later we get the hospital statistics also to that to just see substitutions from primary care into hospital care, which could be another interesting thing to do depending on the kind of hospital care you have nearby. So we can do that in a sub-regional level, which is probably neat. So our empirical strategy for this project is super simple. It's a super classical match difference indifference with a simple two-way fixed effect event study regression, more or less. And before that, we do some propensity score matching to make our regions more comparable. And we match for density and urbanity, so population density, total population, GDP. And we also match for morbidity, so nursing home beds, average population age, elderly dependency ratio, and previous pre-reform life expectancy, or life expectancy in the base year. And before I'll jump into the matching, I'll just show you how the coverage rates in different regions develop pre-reform. So this is the GPs per 10,000 inhabitants for different deciles of the distribution before the reform. Yeah.
How do you observe the local GDPs?
Local GDPs?
Yeah.
They're just an excerpt from the Federal Statistical Office at the county level. So, good question how the Statistical Office computes them, but I think they're computed from the general revenue statistics that is used for the rest of the GDP too, and they have them computed on the county level. Yeah, and here we have this coverage rates pre-reform for different deciles of the distribution. And here the dotted line in the middle, here 2013 is the reform year, or 2012 is our base year. And here this dotted line in the middle shows you the new target, the new general target for all of Germany. And then you can look at this distribution later over time, and you already see what the blocking does, that these coverages go down in all the regions that are over the target, like they should. So this is before any matching, this is just the raw data. So the reform seems to have its bite, but now let's get into the actual strategy. And first, I'll show you the typical balance plot that you have for the matching. So we are able to actually achieve a good match, to have relatively low standardized mean differences between all our targeted match variables, and much better than in the unmatched sample. So in the unmatched sample, you have big differences in hospital beds, population density. So there seems to be quite big differences without the matching, so we kind of need it. Then the question is our support actually good? And we have only around 15% that are off support. So where we don't have a good match for treated units. So actually we can match 88 treatment control region pairs out of 104 potential treatment regions, and then we have 259 control regions, out of which we choose. So we are actually pretty good with the support. So a little bit on the regional patterns of the reform. This is also kind of strange. So some of the things are expected. You have here, you have different clusters of mid-sized cities, here Cologne and the Heidelberg-Mannheim region, the Nuremberg region, but you also have very rural regions. So the Bavarian Forest, the region before the Alps, big region in Hesse. So you have a mix both of many urban regions as intended, but you also have rural clusters that are super rural, where you have lowered access now. And the question is, were these rural clusters before planned right? So is that high GP density you got there just because of the place characteristics? If you're now here somewhere in the Alps and you have to drive 20 minutes to your GP, it's probably a little bit dangerous if you can't drive to one in 20 minutes, but have to drive 30 minutes. Or was it actual oversupply, and is there still good competition? And this is something we can already answer a little bit, and I'll show you later. But first, just the treatment effect on coverage rates. Basically the same plot I've shown you for the raw coverage rates within the distribution. And then you see relative to the reform, you have this decline in the mean number of GPs per 10,000 inhabitants. And it's roughly a standard deviation after 6 years. Yep.
if the GP per population is decreasing, then it means that more and more GPs are there. And I think, am I right?
No, GPs per 10,000 inhabitants means that you have less GPs per capita. It's the opposite. So you have less GPs like expected. For some weird reason, we have the phrasing the other way around in the next paper, so then it will be right. Actually, because it's the phrasing in the law, but everyone was confused by this, so we express it as GP per capita.
What's happening with the vanishing GPs?
So it's mostly missed entry. So it's people retiring and no one taking over the spot. So we also have that already number of GP practices, and you see practices disappearing, and we can actually track these practices with the yellow pages data over time. And who you see disappearing are practices that were around for a very long time. So that were around since the 90s. We can only start in the 90s with the yellow pages, and we see practices disappearing that were around in the 90s and not being taken up. So what we can do, what we also have as a measure in there is a measure of practices being taken over that we calculated from taking the same address and looking if a new practice opens up at the same address. So very rough proxy for a takeover. And this is basically the same picture. Then we have data on the age composition of GPs from the federal registers at the regional level. And for the age composition and the share of GPs over 65, we don't see too much. So if you now do this new Roth controls, it's probably a clean zero in both. So if you do this Rostam-Afschar and Roth thing where you write in the pretrends are bad on this one. But I guess this looks like a zero more or less. So the composition is not shifted in large parts. Also, no shift from self-employment to being employed in another GP. This would be a potential way to circumvent this. If you now want to set up somewhere in the Alps for whatever reason in a region that is not considered oversupplied, or in Berlin or wherever, then you could also get employed at the GP and potentially take over the practice if a place becomes open in the foreseeable future. But there's also no shift here. One interesting measure is actually excess. And the excess doesn't look like there might have been some oversupply. If you look here at the ranges that we have, this is the population weight mean distance to the nearest GP in meters for the region, calculated from this 100-meter grid cells. And you see that there is a little bit of move, but you see the range on the plot, it's from minus 25 meters to 25 meters. So this is a relatively clean zero. Even though perhaps we should scale it more, that it looks more like a clean zero, but it's just a few meters. But what you see is population weight, mean number of GPs within 0.57 kilometers. So you don't really see a big change in excess. So the way to the nearest GP is still there, but the competition of the GPs you have around you decreases. So it's more or less a change from being served by 1.6 GPs to being served by 1.5 GPs on average. So competition goes down, but not. Yeah.
Am I right that these the treated regions are mainly urban, where you have a lot of doctors previously and a lot of population, right? This is, I mean, just looking at the mean distance, that 1.3 kilometers would mean that these are in cities.
Yeah, so these are in cities, but the density on rural places is also relatively high. So
yeah, that would be my question. That how much you can extrapolate to do really rural areas where you have to not drive 1.5 kilometers, but like 10.
So in the super rural areas that are rare, it's a little bit harder to extrapolate. So we could probably look at places within the regions that are more rural. So we have also the distribution of these measures. So we not only have it at the mean, but at different. At higher moments, more happens. But we're not completely sure what to do with it yet and how to do the splits later when we have the health data.
There is a third dimension where you can measure the results is the waiting time for patients in the lobby of the GPs.
Would be a very interesting dimension to measure. At the moment, we don't have good data for that. So that would be a really nice measure. We have some waiting time indices in this web scrape data we use for the other project, but I'm not entirely sure if we can use it here because the pre-period would miss. So this web scrape data we have starts in 2013. So then we wouldn't have a pre-period on the waiting times. Could still do something with that, but
it should raise.
Huh?
It should raise.
Yeah, it should raise.
Yeah, it's no other choice.
Yeah.
No, or
If you are reducing the number of GPs and having constant population, then the waiting time.
or at least the doctorsnál lesz idői time.
Also a possibility. What could also happen with so you could have avoidance of visits. That is also something that could happen. So if provision is down, you could just have no waiting time effect, but also an avoidance of a visit. And for this, actually real health data would be interesting. So
you can simply count the number of visits per GPs and the change of this.
Yeah, exactly. And
this can be indicative.
True, that we can do.
The results in terms of waiting time.
That we could do, yeah. Yeah, so what we thought about, what we definitely wanted to do would be, my colleague Olli Schlenker has a big paper on hospital care. And he has a lot of hospital measures. And one of the main ideas was to look at preventable hospitalizations, like hospitalizations for things GPs can care about. So we have a lot of those, and then waiting times at hospitals. And for this, we actually have relatively good records. And we want to look at this also by different access to hospitals nearby. So if people show up in the ER instead of at a GP, this was one of the things we want to do once we have the health data around. Then I wanted to look a little bit at diagnosis detection. So if diagnosis for specific things go up or testing goes up. So we have a typical age 35 blood test that everyone in Germany can get. Not everyone uses it, but it's one of the things where a lot of things are diagnosed first. So it's for cholesterol and other typical things that are common problems, early diabetes and so on. And then you can look if something changes in the diagnosis rates for diabetes or blood pressure or other things. And for chronic disease management, we can also look at medication shifts once we have the FDZ Gesundheit data. So how often medications are changed in the, so basically you have, I don't know how it's called in English, it's this thing that your doctor gives you where you recipe, it's called in Germany. What? A prescription. It's your prescription and how often your prescription changes. So if prescriptions, it's more or less than a time till the prescription changes that we want as an outcome. Because sometimes they keep staying the same for longer if the management is not particularly good. So then we want to look at specialist referrals also, and pharmaceutical prescriptions on the thing. Wonderful. And definitely also heterogeneity by market structure and demographics. So we then look at rural versus urban regions, income levels, and age structure of the population for some heterogeneity. So this would be the plan, what we want to extend in that paper. Yeah.
For the few days, so understand we don't have this data yet, but then we have will be able to link patients to GPs. So where you see,
so
you see someone with GP because they retired and want to place under is the move to GP, so you can avoid that.
That we can see once we have it. That is then the great thing. But it's not completely available yet, and you got the first part of the project, so we will have some identification, but not many results. So for the second one, we at least have results. This one is the first obvious idea anyone from econ has when he first sees this entry restrictions. You have a clear target, a clear cutoff, and after the cutoff, entry is restricted, you think of an RDD. And this is exactly what we did. So actually, we did not look at this RDD first. There is a second RDD in the rule for subsidy for regions that are undercovered at only 70% of the target. That we will still do, but this has a little bit of a problem because the subsidies differ by the separate states and different timing. So this we will eventually also pick up, but it's on the backlog of projects. And here, once you exceed the under 10% target, no new practice is allowed, but crossing the threshold does not immediately change GP numbers. So they are the same on both sides of the threshold, basically. So this is what we thought first, okay, why not do an RDD and see if there's something happening there, but coverage at the threshold is basically the same. But we still have this regulatory cliff. So in the regions where entry is blocked, monopolist incumbents are shielded. In the regions where entry is allowed, monopolist incumbents are exposed to new competitors. And this gives us a variation in the threat of entry, which is relatively scarce. So most of the literature on the threat of entry is on airlines and concrete and so on. So classical IO literature, but here we have something where we can see it for GP practices. And we use a lot of the common data we have for the second project also for this one. We also have this annual need-based planning reports with one small differences. Here we have these planning areas that are super granular, this Mittelbereich and not Kreise. And we actually built crosswalks for all of them from the municipality data. So a lot of the work in this project was to build super detailed crosswalks on these municipalities. Basically, we keep one Mittelbereich as the same to track it over multiple years if it has the same population. So if it contains the same municipalities with the same population, which is kind of hard to do. Then we use from this annual reports the needs-based planning info again for the coverage rates and the treatment. Then we have the same set of controls that we include, and we again use this geocoded yellow pages data. This time it's actually even more important because we needed to get at the competitive landscape of single GPs, because then you can see which GPs are how far away in which year. One big difference here is that we web scraped the largest practice rating website in Germany. So it's 45,000 GP practices, and it's the largest doctor review platform. And there we have subjective ratings like friendliness, accessibility, satisfaction, opening hours, waiting times, and so on. And these ratings are geocoded and timestamped from 2014 onwards. So you have the exact geocode of the practice plus a timestamp. It's exact to the minute or to the second, but we only use the year from that in the end. So we get more or less on yearly averages. So here, distance to the policy threshold. This map will look a little bit similar because you see the 2013 reform also. Here, the super oversupplied regions are the ones that were blocked in 2013. But then you have similar urban regions around the cutoff. So my favorite example comparison in 2017 are Darmstadt and Heidelberg. You probably don't know them, but they are both mid-sized university cities. So both have a medical university, both are in a similar region. But Darmstadt happens to be open to a new GP and Heidelberg is closed. And think about closing off of a region to be relatively stable for multiple years. So there's not a lot of shifting around the cutoff. So the thing we use is super classical. We use standard non-parametric local linear regression with a triangular kernel and a bandwidth chosen using the MSE criterion based on this Calonico et al. Paper that everyone who uses an RDD does. We of course test the bandwidths. So we have very broad robustness tests of different bandwidths of donut holes and so on. So, but we just do the standard stuff. And we have two key identifying assumptions. The first is no manipulation of the running variable. So in our case, manipulation is kind of hard because there's very little legal leeway for authorities to adjust local targets. So you have these, it's basically bargained out between both groups, between the doctors and the insurances. And usually they have little ability to admit physicians once the regions are officially closed. There are some special rules. For example, if a new nursing home opens up in the neighborhood, then you're allowed to openly admit a doctor even though it's closed. But there's very little leeway to do it. And overshooting the target leads that you have some mass just above the threshold. Because you have an extra GP, so you should have some extra mass than just above the threshold. And we did actually an exercise in the paper that I don't remember at the moment what one extra GP means to the coverage rate for the typical region that overshoots. So you should have some excess mass just above. And typical manipulation would also create excess masses just below the threshold if you want to block the market to not allow new GPs in and shield the ones that are still in there. So this kind of manipulation we probably not see. And then what we also care about is local continuity of potential outcomes. There should be no other systemic differences at the cutoff. How we can't really test that, but how we can test it is to look that we have covariate continuity for a lot of different covariates. So the first one is the density plot that we have. And this is this overshooting pattern that we have. And for this, the first thing we did before we really thought about it, we thought, okay, is our RDD now bad? Can we not use it? We first did a donut hole, but then later found out that this is the overshooting we should actually expect. So, but all the results we have are also robust to using a donut hole and having a really nice density test at the cutoff. And then for the covariates, so we are super good in the covariate tests. So we have a similar share of practices with a profile on this rating side. We have the similar share of people per pharmacy, similar share of foreign-born people, similar gender shares, age distributions, people in need of nursing care, GDP, income tax revenue per capita, absolute population, and population density. So our regions around the cutoff are super similar. And then the first thing I mentioned, the main plot of this paper, people per practitioner, the inverse of GP per capita, just because this is how it's phrased in the law, and we should have changed it already in this paper, but I'm showing you the plots we had there. People per practitioner, no big jump, likelihood of new practitioner entry, really big jump at the cutoff, 20 percentage points reduction in the likelihood that a new practitioner enters. There are still rules for practitioners that are allowed to enter outside of this thing, of the blocking, but this is then special rules like restrictions if a nursing home opens or something. So these are the same coefficients I had on the plot. Then GP composition at the cutoff, nothing. So nothing on the share with known practice, nothing on the share of GPs under 40, nothing in the share of employees. So no change in composition. Also no change in population weighted distance to the nearest GP. So access seems to be super similar. And we're continuous at the number of GPs within walking distance. So we have cities here. So our regions at the cutoff are typically cities like Darmstadt and Heidelberg with 200 to 300,000 people. So walking distance really matters in those places. And here we have the average number of GPs within walking distance. So for the super oversupplied regions in this paper, you have some places where you have 6 GPs within a kilometer. So not many, but some. But around the cutoff, it's super similar. And then the measure that is really interesting for us is the percentage of GPs with no competitor within walking distance. Here we tried the kilometer as the walking distance definition that we used in the paper, but we can use other definitions. We also use 0.75 as robustness and 1.5. I think the US definition was just 500 meters or something. Yeah, and then you see your continuous also in the number of GPs without a competitor. So then we can differentiate these GPs from others. And we can look what happens with ratings for people that have no competitors in walking distance and for ratings of people that have competitors in walking distance. So, and the threat of entry, purely theoretical, should discipline people that don't have a real competitor. So if you have a real competitor, you don't really care much about the threat of entry. Your patients can potentially just walk to the GP next door or within a kilometer. And this is exactly what we see, that the overall ratings are worse. Then we don't find much for waiting times. A little bit of an increase of the waiting time in the practice, but not for the appointment overall that you get. Some decreases on the time taken and quality of treatment, quality of information, and friendliness, where the patient ratings for that are markedly worse for the local monopolists, and nothing for the non-monopolists, for the people that have competitors around. So, and then we have another small exercise that we can make. We can compare people over time, look at them the year after the entry was actually closed. And we have some that have no competitor in walking distance in the last period before and the period after. But you can have this overshooting that the new GP that enters actually entered right next to you. So the unlucky former monopolists. And for the unlucky former monopolists, we have high standard errors, but we find again nothing. So it's really this disciplining effect just for the ones that are affected by it. Then we also looked at opening hours. Small caveat, we only have opening hours for 1 year. So only for 2019, I think 19. So we only have opening hours for 1 year and we find nothing there. Neither for monopolists and non-monopolists. And hospitalizations did not print right, but we also find nothing for hospitalizations and nothing for mortality. So overall, this is now regional hospitalizations and regional mortality. Actually, we would need the hospitalizations of the patients of local monopolists, because on the aggregate, not much is to be found. So we can't really tell you if this is because we can't detect it, because it's a small effect that only affects local monopolists. Or, but at least overall at the region, not much happens. And not much with mortality either, but I wouldn't have expected primary care to matter much more mortality in the first place. Some final thoughts on the two different papers. So we see here that the threat of entry actually matters, but we did not detect any population health effects. And for the other paper, you still have to wait till we have real results. So I would have liked to bring them, but unfortunately, we're not quite there yet. So how long did I take? Oh, early. Yeah.
So maybe obviously the library design isn't it an issue here that you are looking at the margin only, so maybe where the population has the price will kick in out further away from the cutoff.
Yes.
Kind of capturing this design, or is it?
This could be that I can't really capture direct health effects with that design.
So it might be that those are the other.
Yeah, so at least if you look at the pure threat of entry effect, you can't really detect it with just the regional health. So we were also relatively, so we already published this and we were super, we put it as a caveat in the paper that it's
the fact that it's for future.
Yeah.
I don't know how it could be done, but if you.
Yeah.
Yeah.
Yeah. So for our follow-up on GP subsidies, we actually have thought about if we can use the RDD actually cleanly. So to probably super clean to look at actual take-up of entry. But we're not entirely sure if we don't need another diff in diff-like paper to actually look over time and over health effects, because I don't actually expect stuff to immediately happen. So this is also a reason why it was the blocking one first and not the subsidy one.
How can you defend your argument against the counter argument that what if in high competition areas, the simply better quality doctors are selected previously? And what you are measuring is this kind of selection effect. How can you rule out this explanation?
The selection in high competition areas.
In high competition areas, this cutoff point is about 110% or 120%. That the stock of the existing doctors are much higher quality at the start.
At the start, but it should be also directly at the cutoff. So I have the identification from the difference between the person at the 109% coverage rate to the 101% coverage rate. So that would need selection directly around the cutoff. And usually my guess is that more good people want to get into this blocked regions. Blocked regions are typically more attractive. So but I wouldn't guess that it's directly an effect at the cutoff. So it's still the regions that are more popular.
Just around the cutoff. Where you measure the identification is central to the cutoff.
Yeah. So that would think that is still that it's just at the cutoff. That you have just this type of selection at the cutoff is just a little bit less likely than if it's. That would be my main point on that.
Sorry, if I missed that, but have you differentiated between urban and more rural areas in terms of the results? So you said.
So here you can't really do that. These are all urban areas.
Oh, I see.
So it's an RDD paper. It's super local. It's all the urban areas with large cities, basically.
I was interested because in the beginning you said that also the rural areas are sometimes the athlete.
Yeah. So this is basically this other paper there. So the super oversupplied regions are actually the one in the Alps that were closed off. So these had different targets before, and then they're all closed and officially in the new scale at 170% of the coverage. And some of these are rural, or these are the border to Czechia. They're also not very urban. So but again, here in this sample composition we have in this matched sample, this was actually a good point here that we still have the urban regions dominating. So we have to look a little bit how to actually look at access differences between urban and rural later. Yeah.
Do you know anything about this? So do you know anything about the private GPs, but private doctors in general, how available there are, and the private insurance? So you already talked about the US public, basically.
Yeah.
So what about those who actually don't want to have a good insurance from either the company or because they're rich, and rather opt for the non?
So basically, on the patient side, you have to have one of the two insurances. So you have to be either privately insured or publicly insured, and there's some social security thing for the people that cannot afford public insurance, private insurance, but are not covered by a public. So it's special cases like artists and so on. And then from the doctor's side, these are GPs that are registered with the statutory insurance that they can charge from them. And usually this is the highest part of the revenue that they get from there. So from the typical surveys we have from Germany, from a survey of all GPs from the statistical office, we know that around more than 80% of the revenues come from the statutory insurance. So most of them want to treat patients there. There's a few exceptions, and we actually found them in the yellow pages. In super large cities like Berlin, Hamburg, Cologne, and so on, you have a few GPs that are targeting private patients exclusively. But luckily for us, far away from the cutoff, and also not much affected here, perhaps Berlin, but and its border cases. So
yeah, but isn't it possible, you have for the first paper that you have those, especially those very rich settlement or regions where you have the decline for these the number of GPs available, the
Mhm.
previous graph, and you said they are typically those who are retiring, right?
Yeah.
So isn't it possible that they are the ones who are actually quitting the public market and go for the private?
No, because you can also see them in the yellow pages. So it's actually practice is closing.
Thank you very much.
Thanks for your attention.